Hello to everyone. My name is Dr. Ted Noon. I am a public high school principal in Sydney, Australia, and I have been a high school principal for nearly 21 years, and I will be joined a little later by Michelle Roberts, who is the school health coordinator and registered nurse. Firstly, I would like to acknowledge the land here in southwest Sydney where we are presenting, and that is the land of the Gadigal people of the Darug Nation, and acknowledge and pay respect to their long continuous history over 60,000 years. Our topic is incorporating a health team within a holistic learning model in a disadvantaged high school and identifying and overcoming system barriers. The abstract for this presentation identifies that despite examples about the effectiveness of an integrated healthy learner model in high schools, there are continuing system barriers to overcome that pervade expansion of such approaches. The established model in this study incorporates health personnel based in and directly employed by the school. There is highly effective collaboration through such a model between the primary care practitioners, students, families, and critically the teaching and support staff. The integrated model provides support for multiple outcomes within the notion of the purposes of schooling. This work explores a snapshot regarding these barriers and attempts to map them with responses that are identified in practice and current research. This well-established integrated school health learning model forms the basis to this presentation. Schooling and its essential supporting structures, namely health and including various support services, infrastructure and local agents, are inextricably linked but unfavourably acknowledged due to the increasing dominance of market forces over the last 40 years. While Hart's inverse care law, referring to the wonderful work of Julian Tudor Hart, related specifically to healthcare, I argue its extension and application applies to many of the critical system interconnections supporting human development, namely in this case schooling. That is, schooling's effectiveness and equalising outcomes for all is bound within a concerted drive, as the model shows, via an interconnected healthy school community model. This school's model includes an integrated school health team connecting to local social service supports and infrastructures within the community as a pre to post-is model. However, the derivative of inequity in schooling and equally access to health and associated services is inextricably linked and often negatively impacted, especially in the pervasiveness that persists in poor communities. Ultimately, what lies at the heart of the ICL is the continuing acknowledgement of the multiple interconnected barriers as progress moves in small incremental steps towards a holistic model. The following slide highlights the relevant research published by this presenter and colleagues and of significant relevance to this current work and presentation. These three published papers on this slide, in which I was involved with colleagues, directly underpin this continuing and exciting work. More generally, the current slide provides a snapshot of just one of many significant barriers young people in poor school communities suffer as compared to the general community. The data is taken from Best Start for 5-year-olds as they start school nationally. There are 5 domains in the measurements. You can see the disparity of cognitive skills between high SES and low, and the change over 6 years from 2.9 times more developmentally vulnerable in 09 to over 4.1 times just after 6 years later. This 2016 study involving myself and colleagues, while a small study, the findings showed the significance of the number of undiagnosed and poorly managed health issues of students entering high school in a low SES community, and how the addition of a health nurse in the school positively supported young people and families. The following table highlights some of the data. The study looked at the lowest performers in a national literacy assessment upon entry into high school, young people who are 12 years of age, and the nurse intervention evaluated and supported various health issues. A comparison was made with a random sample of students between 12 years of age and 14, that is, students from year 7 to 9. The slide shows the significance of the range between the two groups. Over on the right, for example, vision issues for the random group was 15%, while the low-performing 12-year-olds, it was 53%. ADHD Asperger's was identified at 21% in the Year 7 group and 0 in the random sample group. Critically, in Year 7, students were below minimum standards in terms of their literacy, but by Year 9, majority of students were close to minimum standards. In fact, 42% increased by more than the expected growth. This slide captured data from the school, a student cohort intake group of Year 7s that is 12.5-year-olds more recently. You can see the large percentage of low performers noted in red as 45% well below standard in reading, decoding, and of poor expressive receptive language disorders, that is 27% of the group, and the high percentage requiring glasses, nearly a third of 150 as a random sample between Years 7 and 9. This slide acknowledges hitherto the more broadly based pervasive disconnection in how we address the complex needs of young people, namely in and between various government departments, what we call the silo effect. The reliance on the goodwill of professionals would be the occasional, perhaps sadly, unique yet remarkable way in which young people can receive a wraparound service, otherwise simply unable to access through external channels. In essence, the study quoted here pointed out the lack of acknowledgement more generally when these interventions occurred between cross-faculty professionals, not assisted by the very narrow measurements of school success. Schooling's many critical purposes remain to this day narrowly defined. There are some jurisdictions around the world keen to expand on a more integrated holistic model, namely Wales and of course Finland, for example. There still remains the economically dominated purpose outcome agenda with set targets that miss the many critically important elements of human development along schooling's journey. Overall, therefore, the school community in this study has developed a unique vision and purpose statements based on a more authentic, holistic set of purposes, but finding themselves often remote from the system's more generalised endpoint targets, generally in the form of final exams and global competitiveness and comparisons. This, what I call stickability by the study school, that is sticking with their unique holistic sense of purpose, has brought incremental successes for the school despite enormous community disadvantages and external pressures and barriers. The educational philosopher John Dewey, whose life straddled the 19th and 20th century, had a desire and passion about countering the hitherto issue of dualism, namely the separation of mind and body, and keenly promoted the concept of continuity. One of his areas of interest was the intersection of medicine and education. His intent in bringing together the many variables torn asunder through dualism was for medicine and education to be more faithful to the truth we aim to serve. From this study's perspective, the poor pickup rate of young people by families of the Blue Book, that we call it in low SES communities, which comprises the early years measurements through community health centres and general practitioners, is as low as 18% in the southwestern community in the 0 to 5 years age group. The study school here is promoting the critically important concept of the development of a health learning profile travelling with the child throughout their schooling years. Currently, there is a paucity of transition information as young people travel through schooling. Also, as a result of the low early years health surveillance, this study school is working closely with the Watch Me Grow app concept championed by Professor Valza Epen, which seeks to introduce early years postnatal checks for mothers by creating a safe, mutual process hopefully supported within this school community concept, that is the primary years leading into the high school over time with much improved data, both in health, informing learning. Measuring only what we can as a barrier highlights a persistent failure to capture the full extent of human development, the cognitive, physical, mental, social, moral, spiritual, and aesthetic. This is amplified by the characteristic of an excessive measuring culture. Rather, educators must be connected and, if necessary, reconnected to all of schooling's holistic objectives, especially when measuring and assessing in such a way that they are conscious of how their actions might be understood to have value in terms of end purposes for education to which they desire and are committed. following slide provides a quick overview of how the study school designed its wraparound health learning model. "16 years ago, the school set up its own health faculty, seen in the middle of this slide, directly employing 6 to 7 specialist health personnel integrated within the school's learning context and using its equity funding. They provide a wraparound service for many of the school community's disenfranchised young people and families. They work together with a specialist student support services faculty on the left there and a learning centre staff on the right who work one-on-one with students armed with greater knowledge about the students' health and specific related learning needs." Before I hand over to Michelle, I set these questions from where the school currently stands. Can such modelling help convince change? And we know research indicates local community-based approaches are more likely to succeed than the overall political means by which we make change in such an important topic. But we have to be aware of the barriers. My response in 3 ways is yes and no in terms of convincing for change, by chance, perhaps by circumstance, by patience and persistence. No, while ever political conservatism is wedded and embedded in the market as a means to human development. And yes, it's possible if the political will aligns, it begins locally, young, fresh, keen about using evidence-based and community-based practice. Effective governance, most definitely. I would now like to hand over to Michelle Roberts, a remarkably highly skilled nurse health coordinator. The study school is very lucky to have her many years of high-level experience. Over to you, Michelle. Thank you.
Thank you, Ted, for the warm introduction. I won't go into all the details of my nursing career, but let's say it's been a long and rewarding one. And it continues to be so, working as the health coordinator at this high school, where my skills in primary care nursing, care coordination, and population health manager supports my role. The school sits in an area of intergenerational social disadvantage. It has poorer health outcomes and has a wide and diverse cultural population. Student and family disadvantage is the norm. It's not the exception, but the vision by our school to make a difference is palpable. Ted highlighted the complexities of integrating health and education for students and families in communities of real need. Can we, as a health team, within a school setting, identify and address the barriers our students experience accessing healthcare while living in a disadvantaged community? We say yes. We know that students in disadvantaged areas who lack health literacy, confidence, and agency are less likely to seek referrals, whereas affluent students and families are more likely to demand it. Our students and families are not hard to reach, but they are easy to ignore and more likely to be ignored living in a poorer community. So my role as a health coordinator is to not ignore, but to be the loud voice for those students, to identify their needs, working in the interdisciplinary team to improve their health literacy and advocate for timely health intervention. This approach will have a positive effect on their schooling, their attendance, social integration, and overall well-being. How is change possible? How do we address these barriers at a school level? It's through a lens that is inside looking out, not outside looking in. A lens that starts with the student, the family, and the school addressing their health and social barriers. This child-centered approach ensures we are putting the student at the core of their need and care. We look outwards, addressing any barriers, and taking in all aspects of child development. Addressing system barriers requires this outward-looking lens. And the system barriers are many and entrenched across both health and education. I've worked in both, and I know that they are there. But today I'd like to highlight four barriers. The first one is reduced access to health services. The second one, unidentified health needs. The third is affordable and timely health care. And the fourth is siloed information. The school's interdisciplinary model has developed key elements and practical approaches to address these barriers. But I must preface, these elements and approaches are not in order of importance or establishment, but rather a compilation of lessons learnt over the years. So how do we break down these barriers? We do it through a team-based approach. We improve access to health services through a collective approach. We use an embedded interdisciplinary team and model. So we're using teachers and students, speech therapists, social workers, OT, art therapists, psychologists, all contribute to a comprehensive health screening and provide ongoing support. This team, this interdisciplinary team, promotes knowledge sharing and within the team and across the whole school. The team leverages off each other's skills, ensuring the students' needs are at the core of their care at all times. And this approach is noted to reduce the student stress. Identifying unmet health needs, how do we do that? We prioritise their needs. So we get referrals through existing school systems, including faculty meetings, learning support team meetings. We have Year 7 hearing and language screening. We share the information and education across the school and it follows that student. We have colour coding of existing cases to prioritise needs. We can have up to 72 cases that we discuss at a faculty meeting. We provide feedback to the referral source as well. Affordable and timely healthcare, how do we do that? Well, we reduce the financial barrier. We've developed a list of preferred and affordable and free clinicians. We've sourced vision and dental screening programs that have access to free treatment and glasses. We access culturally appropriate Aboriginal health services. We advocate for NDIS so we can get some funding for interventions. And we prepare information for the paediatrician's appointments. And this helps expedite care and reduces those multiple visits. We've siloed information. We break that down. We share the information. We establish and promote interagency information sharing. The continuity of health needs and care between primary schools and high school. We improve the timely access and to developmental assessments through school-based referrals to seek a diagnosis. And we utilise and expand existing school document system. Coordinating case conferences between relevant stakeholders to provide transparency within the confidential framework. All of the above are but a snippet of the work the team undertakes on a daily basis. To capture the full extent of a human development, taking in their cognitive, their physical, their mental, social, moral, spiritual and aesthetic, a team-based approach is paramount if we hope to have a positive impact on a child's overall social and emotional well-being to improve their learning outcomes. We work as one towards a common goal. Reducing system barriers requires a whole of community approach, an integrated health and education system, and most importantly, but the most challenging, a political and an economic paradigm shift. If we address the barriers and implement interventions, the earlier the better, in each school where disadvantage is the norm, the positive effect on schooling, social integration, attendance, and overall well-being will bring about the winds of change. It will have a ripple effect from the ground up. I acknowledge that this is not a local school issue, but rather a state, federal, and global issue, which I know resonates with everyone here today. System change is necessary and it will not be easy, but embedding school-based health models, building the foundations of integration, education and health intersecting, will bring about change through practical and tangible ways. Thank you for listening, and I encourage you to be the nurse, the loud voice who brings about change. Start building those foundations. Start the groundswell, one nurse at a time, one school at a time, one student at a time. Thank you.